Hello everyone, welcome to another education session. Today we are diving into a crucial topic, understanding papillary carcinoma of the gallbladder. This comprehensive guide is tailored to equip you with knowledge needed in the complex world of gallbladder pathology. Papillary carcinoma of gallbladder is a less common but significant malignancy. We will explore its features, diagnosis and management strategy in this session. Understanding the nuances is essential for providing optimal patient care. First, we will give you a case scenario, then we will give you the imaging findings, then you have to make a plan for this patient, and then we will share our management plan at the end of this video or as a separate video. Friends, this was a 39-year-old female with history of pain abdomen for last 2 months, which was insidious onset, right hypochondrium, mild moderate severity, dull leaking, non-radiating, non-progressive intermittent pain. There was associated history of dyspepsia, bloating present, no vomiting, no red flag signs in the form of loss of weight or loss of appetite, and there was no previous surgery or comorbidities. The journal physical examination and the abdominal examination were unremarkable. There was no lump palpable. The routine workup, biochemistry, LFT, CBC, and the tumor markers were all within normal limits. On ultrasound, there was a heterogeneous hypoechoic soft tissue lesion filling almost whole of the gallbladder lumen, measuring 2.5 into 2.6 into 4 cm with cholelithiasis. The fat planes with liver were maintained. CVD was not visualized. There was an incidental finding of ectopic and mal-rotated right kidney with right adnexal complex cyst, query endometriosis. So, if you remember our talk from thick wall gallbladder series, then this is a case where the thickness is more than 20 mm. So likely we are dealing with this carcinoma of the gallbladder. Friends, it is required that you watch our previous 3 videos, 4 videos in fact, in thick wall gallbladder series and other videos on gallbladder cancer to have a better understanding. On CT scan, CCT abdomen, there was a heterogeneously enhancing soft tissue seen in GB fossa, likely malignant. There was no locoregional lymphadenopathy or any evidence of metastasis. Ectopic right kidney, malrotated right kidney with complex cystic lesion in right adnexa were confirmed. These are the axial images of the CT scan, contrast and CT scan. Here you can very well appreciate that there is this enhancing mass in the gallbladder lumen, which is occupying most of the lumen of the gallbladder, and there is no local infiltration. In these close-up views, this enhancing mass as highlighted by the arrow is very well appreciated. And the fat planes with duodenum and liver are maintained. There is no IHBRD, the CBD is not dilated. In these sagittal images, the right ectopic kidney, which is in the midline with hydronephrotic changes, is very well appreciated. Along with in the right upper panel, there is this echogenic, enhancing sludge-like mass in the gallbladder lumen with well-maintained fat planes. In these pelvic cuts, the complex adnexal cyst mass is appreciable, but it was not METs that we confirmed with the help of a PET scan. So friends, the imaging finding which I shared with you are quite characteristic of the papillary variant. You have to remember these and keep these photographic memory in your mind. So if you see these kind of imaging in a patient of carcinoma gallbladder, you are likely dealing with a papillary variant of the carcinoma gallbladder. Carcinoma gallbladder is there, but likely we are dealing with a papillary variant with additional finding of right ectopic kidney and a right adnexal cyst. So now comes the question for you guys, that if you are the managing surgeon or the trainee or a senior resident who is planning the surgery for this patient, so how will you plan? Like extended cholecystectomy is required for any case of gallbladder cancer after staging laparoscopy. But what will you do, or what will be your pre-op or intra-op consideration or the preparation for this patient if it turns out to be papillary? So whether it will require any additional procedure for the CBD, whether prophylactic CBD or hepatic duct resection is required. So how do we deal with? These are all the questions I am posing for you. Make a plan and we will discuss at the end or as a separate video in this video tutorial. If we talk about carcinoma gallbladder, it is the most common biliary tract malignancy that all of you know. The highest incidence in child, northern India, where we reside, natives of Northern America, higher older age group, more affected, female more than male. Presentation is with abdominal pain in 85% of cases, jaundice 43%, weight loss in 42%, and lump in 9%. 5-year survival is 21.3%, but it is older data of 2010. Presently, it is better, around 30%. And median survival after resection is 16 months and 2 to 5 months of the untreated patients. The main histology variant of the gallbladder cancer will be papillary, mucinous, squamous, or unspecified, out of which papillary will be somewhere around 5%, and most of the time it is adenocarcinoma. The incidence of papillary carcinoma is around 5% of all the GB malignancy, as I said. The 5-year survival is much better if we are dealing with a papillary variant. So if we have a diagnosis of papillary cancer, then it's a good news for the patient. So it is 76.9% in GB papillary adenocarcinoma versus 30%, 31% in GB adenocarcinoma. There is an early presentation, 64% are localized. This prognosis is better because there is exotic growth, early obstructive symptoms are there, we will discuss more, and there is a delayed invasion into the GB ball, and the main prognostic factors will be T stage and lymph node involvement as in all other malignancy. So delayed invasion into the GB ball, that you must have appreciated in the case scenario which I discussed, because there was a large mass occupying the whole lumen of the gallbladder, but still it is not invading into the liver, and the GB ball was also looking normal, well maintained contour. So these are the Kaplan-Meier survival curve, and you can very well appreciate that the survival is much better in case we are dealing with the papillary adenocarcinoma. The mean age of presentation is in 7th decade. Female predominance is seen as in all the hepatobiliary malignancies. The symptoms are abdominal pain, weight loss, nausea, jaundice, fever, and fever is more common because of the exotic growth pattern and friable tumor emboli. And patient can present with a jaundice because of the tumor emboli and direct infiltration, which I will discuss more. And there is association with the gallstone similar to adenocarcinoma. So the presentation is a bit late in the 7th decade as compared to the 6th decade in GVC. So jaundice, if you remember my talk in the gallbladder cancer series, it's very ominous sign, and usual survival is less than 6 months, and the chance of resectability in a gallbladder cancer is less than 5%. This is the data which we have quoted in that series also. So these patients, you have to understand that the jaundice can be because of the direct invasion of the CBD by the tumor, or there can be tumor emboli. So tumor break away, it's a papillary growth, they break away, they go into the CBD and they lead to the obstructive features. So I share another case with you guys that we were evaluating a patient of GBC and who presented with obstructive jaundice, high jaundice around 10, obstructive pattern. And as we were evaluating, so as I said, it is an ominous sign. So suddenly the jaundice of patient disappeared and he became totally without any jaundice. So normally this finding will happen in case of a ampullary variant of the periampullary, but we were not sure at that time. We were not aware of this finding, and so later on we realized that it was the tumor which was blocking the CBD and cleared. As I said earlier, we are also becoming wiser as we are making these videos for you guys. So the learning is mutual. On gross pathology, there will be pedunculated or sessile polypoid mass which project into a lumen, fills the lumen, and there is a minimal invasion of the GB ball. The external ball may be unremarkable. The pathological examination, there will be papillary proliferation of epithelium with delicate fibrovascular stalks, and mostly these are very well differentiated tumors. This is an important part of our discussion, that you have to understand this mode of spread of these cancer to the bile duct. So first can be, as depicted in the first pic, there is a direct contiguous spread from the primary. So there is invasion which is going into the CBD, leading to the obstructive jaundice. Or there can be intramural spread in papillary adenocarcinoma, which is characteristic that there is no external invasion and the tumor is going submucosally. And there can be isolated mets also in skip mets. Again, these are the features of the papillary. And from the another part, how the CBD can get obstructed will be from metastatic lymph node in the porta, which invade the or obstruct the or compress the CBD. So these are the modes in which gallbladder cancer can present with the jaundice, out of which the type 2 and the tumor emboli is quite characteristic to the papillary carcinoma. And if you have any questions related to this talk, you can connect with us on our app in the chat option or in the comment section on YouTube. And I hope the lesson learned in this talk will help you to manage better your patient, and that will serve the humanity better. And for a better learning experience, please download the app. For exclusive early access to the premium HD content, you can join the channel membership or download app. The link for everything is given description and pinned comments. If you're watching this video on our YouTube channel, don't forget to like, subscribe and hit the bell icon for all the future updates. Stay tuned for more educational content, and as always, keep striving for excellence in your surgical journey. Thank you very much. Happy learning.